When I heard that we were going to be hosting this journal club, we were talking about landmark speakers and landmark papers for hepatobiliary GI, and obviously Chris Fox was the first person to come in mind for me. I got to do residency down at Irvine, so I got to spend a lot of time hanging out with Chris, and he's obviously a landmark person in point-of-care ultrasound in emergency medicine. For those who might not know Chris, I think everyone probably does, but Chris is a professor and the chair of emergency medicine and the current director of ultrasound and medical education at UC Irvine. Dr. Fox's clinical research interests lie mostly in emergency ultrasound. He's dedicated to promulgating the use of ultrasound at point of care through research, teaching, leadership, and clinical expertise, mirroring UCI's mantra, discover, teach, and heal. I obviously got to spend a few years with Dr. Fox, and he is the reason that I went into academics and did a fellowship in emergency ultrasound. So he's a person near and dear to me. With that, Chris, I understand you were going to be able to talk to us a little bit about one of your landmark studies in hepatobiliary GI ultrasound.
Yeah, well, thanks for having me here. This is awesome. This is, you guys can hear me okay? Cool. Yeah, this is it's exciting to connect with my ultrasound community and my tribe, who's been so good to me over the past 20 years, and just it's so cool that within our specialty, our broad specialty of emergency medicine, we have like our own little carve out, people, like about a couple thousand of us now who are kind of all know each other and get to interact and, sort of mentor each other and help each other out and stuff. And it's so fun to just go to conferences, see all my friends and jump on these Zooms and see my friends and all the faces. So thanks for having me here. I've been really busy with chair life. So my ultrasound director quit like 3 weeks ago. So now I'm the ultrasound director. I'm the ultrasound fellowship director. I'm also in charge of the ultrasound medical education for the medical school, the 4-year curriculum with 350 butterflies. So all of that comes my way. And then my side gig as a department chair has been feeling a little overwhelmed lately. And I have a job ad out there if you know people who are looking for jobs. I need to hire at least one person, probably more like 3 ultrasound people to build my team back up. So just thought I'd throw that out there, and whenever I get a chance, I'm recruiting. And so, yeah, so this concept came up about the common bile duct from one of my old fellows, and probably somebody here some of you may know him. His name is Rusty Yoshida. I think Ken Kelly, you might know him. He trained at Davis. He came down, did my fellowship. He's a guy I grew up with. We were best friends and both became doctors, and he ended up doing my fellowship. We had a great time that year, obviously. But he was like, why do we spend so much time looking for the CBD? It doesn't really seem to matter. Like, when you're good at ultrasound, it's fun it's just something you're always doing. But when you're trying to, bring along that new person, that novice, that person that you're just trying to bring along with ultrasound, and it's like trying to, like a squirrel's coming over to eat a nut out of your hand. This is how Rusty described it to me. He's like a squirrel's coming over to eat a nut out of your hand, and you're showing him the gallbladder and everything, and all of a sudden you start talking about the Mickey Mouse sign and the CBD, and it's like this little sliver. No, you can see it. It's right there. And then the squirrel just runs away, and they're like, "Forget this. I'm not going to learn ultrasound." And so I think in that sort of sense is why he wanted to, kind of ask that question a long time ago, probably over a decade ago. And I was more like, no, dude, it's the CBD. It's easy. You just stretch out the portal vein and you'll see it. It's up there. Why are you trying to make such a big deal about it? And I think though, to novices, it is like one of these extra level things that they just can't get their head around. And so anyway, so we set out to do this. That was the whole vibe behind the paper, was like, there's got to be some other finding. Like if the CBD, if there is a biliary issue going on and there is CBD obstruction, if we need to know about that, there's probably something else going on as well that is going to, test positive from either a laboratory standpoint or a sonographic standpoint, whether it's a sonographic Murphy sign or wall thickening or pericosic fluid, or like some other lab abnormality, whether it's the lipase or a T-bili or whatever, that something else is going on to like result in a dilated CBD. So that was kind of the concept behind the paper. And so when Bryson asked me about it, I was like, yeah, cool. I can chat about that. And I just, And I was going to put together like a whole presentation about it, but then Michael Prats did such an awesome job reviewing the paper that if it's okay with everybody here, rather than reinvent it, was Michael Prats on here? He may even be on here. I was just going to go ahead and share that Gel podcast website, and we can just kind of go through it from there. Because with all massive due respect to Michael Prats, I mean, this is like, this is very pretty. And I thought, why don't I just do this instead? So this is the paper here, utility of CBD. And by the way, there's some nice images here. Here's your portal vein. Here's your nice dilated CBD. I could, when it comes to all things gallbladder, I like it so much because using that curved probe a lot of the times, and that curved probe just makes such pretty pictures. And you can see here it's like, and that's a nice curved probe in the gallbladder. And then, oh, portal vein. Oh, look who it is right above the portal vein. We see a little snippet of the CBD. Let me make this bigger so you guys can see it. And then same over here, then you stretch out the portal vein, it's longitudinal plane, and then you see like just right above it, there's a nice thick dilated CBD here. And usually I tell people, look, unless the CBD is approaching the size of the portal vein, I don't really stop and drop calipers on it unless it looks obviously like I'm concerned or prominent. And so for the majority of the time, I'm just kind of driving along and I see a little sliver up here like this one, and I just move about my business. So basically what we did here was, the question was, does it matter to measure the CBD if there's other findings going on? And it was a prospective observational study, all patients coming in with potential for biliary pathology. And the outcome was a number of patients with complicated biliary pathology identified by CBD dilatation that did not have any lab abnormalities. So is there that one isolated, just for some reason, dilated CBD and nothing else comes back positive? We're looking for that needle in the haystack. But to find a needle in the haystack, admittedly, 158 patients probably won't do that needle in the haystack for you. I mean, so this is like right off the bat, the paper kind of, that's a major limitation of this paper, is that our N was pretty low. And to do this kind of thing right, you'd want another person to, like a multi-center study with, probably closer to 1,000 or 2 patients. But anyway, so we took a crack at it in a short period of time. The other thing is, we do get a lot of biliary stuff that comes through the ED, right? I mean, it's amazing how much like this is really a pretty high end of patients that can gather pretty quick, that you can gather pretty quickly, as opposed to something like necrotizing fasciitis, which took us like 4 years to get 100 patients, or 3 years. Like this study, like 158 patients, you can bust that out in a few months, usually with biliary stuff. So that's what makes any study that you're going to tackle. Think about like your, the prevalence of that disease in your patient population. And I think that's another kind of a pro tip here about any kind of study you're doing. If you see a lot of patients with, like right now, we have a lot of patients with methamphetamine use, and it's like, oh, we should do a study on that. And so like in the first week of the study, we already have like 30 patients with, blown out hearts from meth that we picked up in the first week of the study. Went really fast. And so look at your patient population and see what you got, what you're working with, and think about how ultrasound might, work with that patient population. And so anyways, to get at just the results, we had 0 patients in that small N of 158 with any complicated biliary pathology that had a CBD dilation without any other signs. And so your positive likelihood ratio was 2.43, your negative was 0.85. So some of the take-home points here were that, and this was published in the American Journal of Emergency Medicine in November 2017. The take-home points here: combined dilatation did not contribute to diagnosing complicated biliary pathology. Dilated CBD is only weakly specific for complicated biliary pathology, and wall thickening was actually the most common sonographic finding in complicated biliary pathology, whereas less than 50% actually had gallstones. And so we're really looking at that wall thickening. The background we kind of already know about. I went over that. The question of the population, I think we covered most of this stuff. We did exclude patients who were pregnant, who were incarcerated, who wouldn't consent, didn't speak English, or didn't speak Spanish. We didn't enroll we have a lot of Spanish-speaking population, so we had all the forms translated for them, and we had translators for that. And then we also excluded people who could not follow up. So it's prospective observational, and they got some laboratory studies, and these are all patients who were getting POCUS, the Wrapup quadrant. And the gold standard was determining what the ultimate diagnosis was in the ED or the hospital, if they got admitted in the hospital discharge final diagnosis. And we called these patients back in 2 weeks to see how they were doing and if there's any change in diagnosis, or did they return to the ED or get re-hospitalized. And so we sort of classified these diagnoses into 3 possible categories: non-biliary, uncomplicated cholelithiasis, basically just gallstones with nothing else going on, or complicated biliary pathology, which is any biliary diagnosis that required hospitalization or a definitive treatment. So that which included acute cholecystitis, choledocholithiasis, cholangitis, and also pancreatitis. So our statistician, and just a side note on Craig Anderson, our statistician, he's a PhD in biostats, and he was with the department for almost 20 years and was so important in the creation of so many papers. And, at first we were just handing him loads of data and saying, dude, polish up this turd of data and make it something we can, publish. And then it kind of moved from that to, and then he was like, dude, why don't we meet ahead of time and I don't know, have a discussion about methods so I don't have to do this back end, drama every time. And so we really started to work much better with him. And then he retired and now we have a new MD PhD statistician we work with, Dr. Sohail Sadat, and he is amazing. But we're smarter now, and he comes to all of our ultrasound, our weekly ultrasound research meetings, and he rounds on all of our studies with us. And every time we start getting some ideas about a new study, he is so critical to how the methods are set up, because he's going to tell you, he'll say no, for 10 different ways we're going to set up. And then he'll suggest, why don't we do it this way? And we're like, oh, dude, that's so right to do it that way. And so, so it's really helpful, I think, to have that statistician in your presence. And if you don't have that person, it's stuff you could totally learn yourself. DIY stats, something you could definitely do. But if you have somebody who's willing to jump in, even if it's for authorship status, if you work at a university, there's usually somebody running around campus somewhere who's looking to, jump on papers, and these statisticians become part of the authorship every time. And it's cool because when you write in the paper, the whole results section is kind of basically written by them. That's one giant section. Then they can usually weigh in on the methods here, and they edit that section pretty heavily for you too. So very helpful to have these folks around you when you're doing research. And I'm not sure who Dr. Gottlieb uses for his ghostwriter. Obviously, it's must be a whole team of people, because every time I open up a journal, it's I'm just article after article after article. It's awesome. Yeah, I'm not intimidated that you're on this call at all, dude. So we basically did history, physical, and they got enrolled if there's any conservative biliary pathology. They went on to get that Wrapup quadrant POCUS. And importantly, the person doing the Wrapup quadrant POCUS was blinded to any of the lab results. And so that person, if they knew about the labs, they had to find somebody else to do one, and which is easy to do, with, several tendings on and multiple resins running around. So, but so that ended up getting done, and then the data got collected: age, gender, BMI, sonographic findings, lab values, et cetera. And final diagnosis determined from the ED discharge documentation or the hospital discharge summary, including any other results from either surgical pathology or maybe they got ERCP. Patients got contacted again 2 weeks. And if we couldn't reach them, we tried for a month. And then finally, if we just couldn't get a hold of them, they fell out of the study. A total of 26 different emergency physicians did enroll patients. So that's another, I think, strength of any study that you want to go out and do, is to have as many, sonologists as possible doing the scans. Because if it's just the expert fellowship director, fellow person doing it, who's already done 2,000 of these, it has less external validity, I think, to the folks who are deciding whether or not to tackle this on their own. So I think it's good to have a whole swath of different people at different levels of training to do this, whatever study you're doing. So we try to do that here. We had 26. We probably could have, because between our residents and our faculty, we have 50 people that could have been doing it. But so maybe about half of everybody was able to get it done. So no study specific instructional workshop. This was just like everybody kind of knows how to scan and they got after it. But they at least had, the minimum of 1 hour didactics and 3 hours of hands-on basically across the board at some point in their career. All 26 of those people had that. And so again, I love that curvilinear probe. This is just makes such pretty pictures. But if you couldn't get through the rib, if it was like a patient where you had to kind of roll them on their side and get between the ribs and this wasn't cooperating, then the phased array probe works fine for that as well. And they look for presence or absence of gallstones, pericocystic fluids, sonographic Murphy's, measurement of the anterior gallbladder wall and the CBD, and wall thickness greater than 3 millimeters was considered abnormal. Positive, obviously, pericocystic fluid, sonomurphy's, and a CBD greater than 6, or if greater than 60 years of age, we used an extra millimeter per decade of life. And Michael Pratt's put in this write-up, hey, click on 5 minutes sono to see about the gallbladder. Excellent idea. So we enrolled 167, excluded only 9, and 3 cores were female, median age of 35, BMI of 28. Kind of starts to go along with, some of those things we hear about biliary stuff, right? Half the patients walked away with a non-biliary specific diagnosis. 51% had a biliary specific diagnosis like uncomplicated cholelithiasis, complicated biliary pathology. So 27% were uncomplicated, 24% were complicated. And of those that were complicated, biliary pathology we defined as 8.9% had cholecystitis, 12% had choledocho, only 1.3% or 2 patients had extrahepatic ductal dilatation. So pretty small number there, just a couple of those patients. And 1 patient had hepatitis and 3 patients had pancreatitis. And so these last 2 diagnoses here was based on laboratory values. 63% had 1 abnormal labs, 46% had gallstones, 44% some other abnormal finding like wall thickening, pericocystic fluid, or sonomurphy's. Couldn't find the CBD in only 7 patients. And directly, it would have been interesting to see these 7 patients, more details about like who was scanning, what was the BMI, like things like that, but we didn't do that, unfortunately. Dilated CBD visualized in 20 or 12% of the cases. So that's pretty interesting. Primary outcome, patients with complicated biliary pathology, abnormal labs, almost 80% with the biliary pathology. Abnormal point of care ultrasound, 74%. Gallstones had 46%. So you can't just, rule out pathology just based on the absence of gallstones, because only 46%. Dilated CBD, 23%. So that was pretty significant. Only 2 cases of complicated biliary pathology without laboratory abnormality or POCUS abnormality, but neither one had a biliary CBD dilatation. They both basically went up with choledocho lithiasis, or got diagnosed with choledocho, I should say, and one of them had gallstones. So other findings, all the patients with CBD dilation, 10% did not have one abnormality or abnormal POCUS besides having gallstones. So 1 had gallstones, but radiology performed ultrasound showed signs of uncomplicated cholecystitis. 1 didn't get described, and I can't remember what that was about, but they said not to have biliary pathology. Only 1 patient had a visualized CBD I should say 1 patient without a visualized CBD had complicated biliary pathology, and that patient was the elevated lipase patient with pancreatitis. So you take all this together and you start running some test characteristics on this. And so the sensitivity for just CBD dilation diagnosing your biliary pathology is actually quite low, 23%. So a lot more going on there. Specificity was pretty good, 90% for that finding. So the likelihood ratio, again, of just CBD dilation telling you've got some biliary pathology was 2.4%, negative likelihood ratio 0.85. So a dilated common bile duct was found in almost 10% of the cases of uncomplicated non-biliary diagnoses. So a lot of data is sort of unpacked there. A lot of limitations, though, for sure, I'll tell you. And, when it comes to these kinds of limitations, it's like, yeah, we sort of get these papers done, we get them published, and some lower tier journals, but at some point we all need to be asking ourselves, better questions and going after larger sample sizes, multiple centers, consecutive, not convenient samples, things like that to kind of cross off some of these limitations. But all that being said, there's really no, our POCUS findings weren't overread by any radiologist or expert, or even an expert in POCUS. So they were just sort of all interpreted right there at the point of care. So maybe there could have been some inaccuracies in some of those interpretations because it was some more junior people that were making those, or less expertise people. This could make the test accuracy results actually either better or worse. But this, actually, whenever I see this write about this limitations, it's kind of a copy paste boilerplate paragraph here. However, this does reflect what we actually do in real practice, because we're using our own scans to make these diagnoses. Sort of that's how we roll. Our gold standard was a discharge diagnosis. Again, not since not every patient received a definitive study like an MRCP or an ERCP, it's really impossible to say that something wasn't missed. But ultrasound is known to be fairly accurate on these diagnoses. This may have not thrown the results off too much. Now we did another study, another prospective gallbladder study years ago, with like maybe 160 patients, and we compared ourselves to radiology for the diagnosis of acute cholecystitis. And we actually had slightly, on the gold standard was pathology specimens on those who got their gallbladders taken out, and phone calls on the ones we sent home. So when you compare radiology ultrasound to point of care ultrasound, and you use pathology specimens as the gold standard, for the diagnosis of acute cholecystitis, what you see is that the sensitivity of the person doing the point of care ultrasound is a bit higher than the radiologist, whereas the radiologist had slightly higher specificity there in that setting. So, but I mean, really splitting hairs. The two were quite similar to one another, and were basically equivalent. So, so we felt like after that study that we thought that there wasn't much to add by getting a radiology ultrasound on a lot of those patients. And so that's why I think we kind of thought of ourselves as that, as the gold standard. Average BMI was 28. We all know what that means. No cases of cholangitis or malignancy. Malignancy is a tricky one. That's a morphologic diagnosis. You sure wouldn't want to miss that. And that's really where I think that a lot of the, sort of liability lies here. When you see sludge layering out and that, meniscus of sludge there in a gallbladder, it's sure better be isoechoic and have no areas of lumpy or bumpiness to it, because sludge and malignancy, cholangiocarcinoma, can look actually quite similar. And so I sort of a little nervous sometimes. That's one of the areas I definitely feel like we should all, as a community, spend a little more time talking about. And whenever I have it come up in QA, we save all those just as sort of extra examples. And instead of calculating the test characteristics of a dilated CVD, which everybody suspected were bad, it would have been nice to calculate the test characteristics of like gallbladder thickening or pericostic fluid or sonographic Murphy's or other labs for diagnosing complicated biliary pathology. They obtained the data to do it, but not enough information to provide the manuscript to calculate it. And I don't have a good answer for that directly. I would have to contact Craig Anderson and see how get him out of retirement and ask him that very question. Probably it had to do with, I'm sure it was thought of, and maybe the data wasn't savory enough to do that. I don't know. It's a good question. That's what I'm suspecting, being completely honest, but I don't remember. So in the discussion, what do you guys think? Should we still try to find a common bile duct? I personally do, because it jumps out at me. But, the question is, do we, when you're teaching like, an introduction to POCUS, and you're trying to bring as many people along as you can with that, at what point do you start adding in the layer of the common bile duct? I think is probably the most sort of the question we're at. Is it more of an advanced technique, or are you going to freak people out if you start getting too much into the anatomy and the details? And I think that's probably what's up for discussion. So, yeah. So Take-home points, basically, CBD did not contribute to diagnosing complicated biliary pathology in the study. Dilated CBD is only weakly specific for complicated biliary pathology, and wall thickening had the most common sonographic finding in complicated biliary pathology, whereas less than 50% of gallstones. Now, they gave it 4 probes. I don't know out of how many is that out of 10 or 20, or I'm not actually sure. Oh, it's out of 5? It's out of 5. Oh, so that's pretty good. Yeah. And I'm gonna stop sharing. Yeah, great study. Numbers are low. Certainly suggests that when you can't find the CBD, rely on your lab findings. Yeah, great. I'm gonna where we kind of start talking. Okay, so many windows open. Where is this thing?
Nice. Thanks for going over that, Chris. It sounds like your main take-home points are that you're still going to look for the CBD, but you're probably not going to lose sleep if you can't find it. Or, for instance, if one of your residents can't find the CBD. Is that a pretty good summary for that study for you?
Yeah, that sums it up pretty good, actually. That's perfect. So this was the other thing I was going to share really quickly. It got the study got taken up in New England Journal of Medicine's Journal Watch. Dr. Pound's emergency physician, who is the deputy editor for emergency medicine articles that make their way relevant, or just does commentary on certain things that he wants as new gem folks to see. And so he did a little thing on basically summarize what we talked about already. But I just thought it was sort of interesting that it's not common that one of my articles, or an point of care ultrasound article gets thrown up in New England Journal, and I think it's interesting to see that there's readership out there that find this interesting, just besides us point of care ultrasound nerds are here on this call. So that's why I was trying to bring that up. But yeah, I'll stop sharing now, and we could bring it up for discussion. What do you guys? What's on your mind?
Obviously, I love nerding out with you, and I'm really excited that you were able to come and chat with us about this. And it's one of the really fun studies that I like. So, Chris, thanks for coming and chatting with us. I do think we have some time for questions. I have a couple for you, unless anyone else in the room has some questions as well.
I have a question. Dr. Fox, you published another study with Biliary saying that absence of gallstones could rule out cholecystitis, and then Michael Pratt seems to interpret this study in a different way. How would you jibe those two studies?
Let me bring up that other one. Yeah, I think that the other one, I have to bring it up to make sure I don't say something stupid. Hold on, where's that other one? So what we did was, with that other study, we took a bunch of prospective data that we had from that prospective gallbladder study that we did a long time ago, and I'm trying to bring it up. But if I remember correctly, what we did was we went back and we took that data set from those. Remember that study reference where and we used the surgical pathology as the gold standard. We went back to that data set. Somebody smart, Mike Manchin, he goes, hey, can we get access to that data set and go back to it and ask the question a different way, retrospectively, to say it was like the absence of gallstones question, and exactly what you just said. And so it was a retrospective way to take a
We'll get him back as soon as we can.
I think we've lost
Nick,
Chris.
do you want to stick with waiting for him to see if he comes back, or do you want to initiate the?
I think let's introduce the next set, and then if Chris gets back, we can finish that conversation, because I think it is an interesting point that so few of these, well, not so few, but only 46% of these patients in the study that we're reviewing today had gallstones to begin with. So for the next set, we're going to break up into breakout rooms.